Thank you so much. Good evening, everyone. Thank you, Shona and Sudeep, for giving me the opportunity to talk to you today. So this is a rapid review on translational science. I have 5 papers to present. I have slightly changed the order. So it's in patients with ER positive, HER2 negative breast cancer mainly. So the first 2 are on first line advanced breast cancer. The third one is on second or later. One is on neoadjuvant. Then the last one is on adjuvant treatment for these patients. So all of these papers are relating to cancer biomarkers or liquid biopsy, which is something which is quite pivotal in our clinics today. Patients ask us about it and talk about it. So you have circulating tumor cells, circulating free DNA, circulating tumor DNA, which could be part of cfDNA or CTCs as well. And then you have circulating microRNAs as well, which are as a result of necrosis, apoptosis, or secretion. The detection can be PCR and NGS based, and the NGS based depends on what the number of genes are in the panel. So there is a lot of complexity involved in these studies. So there are studies for screening, for before treatment to identify actionable mutations, prognosis, predictive biomarkers, during treatment to look at clonal evolution, after treatment. But I would urge you to look at all the 5 papers that I present. Look at analytical validity, the clinical validity, and the clinical utility before you start using it in your practice. And of course, the others, regulatory approval and clinical workflow comes after that. The first paper is about circulating tumor DNA and serum thymidine kinase 1 activity match dynamics in patients with ER positive, HER2 negative breast cancer. We know that ribociclib has shown a significant improvement in outcomes, irrespective of the endocrine backbone is used, and also irrespective of which line of treatment is used based on the Mona Lisa trials, though we don't know what the predictive biomarkers of response are with any of these CDK4/6 inhibitors. So the biolaterally study had shown that, that doing a dynamic monitoring at baseline and day 15 of ctDNA and TKA has a prognostic and predictive value for both of these. And in this study, which was presented at San Antonio, at ASCO last year, of the 287 patients, 241 patients had both the samples available at baseline and at day 15. And what they showed was that the clearance of ctDNA or TKA after 15 days of treatment was associated with a lower risk of progression. And based on these data, the authors divided the patients in 3 groups. Group 1 was wild type, where there were no mutations detected in the blood, there was no circulating tumor DNA, and TKA negative. Group 3 was ctDNA positive and TKA positive, and they showed that the patients who were in group 3 did significantly worse compared to those who were wild type and TKA negative. So the conclusion was that combining early dynamic assessment of both of these biomarkers may improve prediction for patients treated with ribociclib and letrozole. So I feel that if the patients are ctDNA and TKA positive at 2 weeks, and if this test was cost effective, would you change the treatment plan and not give them ribociclib letrozole? I don't think so. Yes, it is hypothesis generating, but is not ready for use in the clinic. And of course, there are a lot of issues involved with the validation of ctDNA processing methods and the TKA assays. The second paper looked at circulating tumor cells driven choice of first-line therapy for hormone receptor positive, HER2 negative. Now, choosing between chemo and endocrine therapy depends on the clinician's knowledge, experience, intuition. There is no validated decision-making algorithm, and actually, if patients are in visceral crisis, we say that probably we should give them chemotherapy, but there is data to show that even if patients are in visceral crisis, with the CDK4/6 inhibitors being around, one can go for CDK4/6 inhibitors plus an endocrine backbone. So this study looked at the circulating tumor cells, a validated marker, to see whether it can predict whether you should go for chemotherapy or endocrine therapy. So all women who were hormone receptor positive, HER2 negative with a PS of 0 to 3, who could receive both chemo and endocrine therapy, were recruited in this trial. And the treatment, the patients were divided 1:1 randomization into clinician versus CTC-based choice. The CTC-driven choice arm, so patients with a low CTC count were given endocrine treatment, high CTC count were given chemotherapy. And the clinician-driven choice arm, patients with clinically low profile had an endocrine treatment and high profile had chemotherapy. As you can see, in the 25% patients who we would label as clinically low risk but had a high circulating tumor cells at baseline, there was an increased overall survival benefit with the use of chemotherapy, with the survival benefit being 16 months. The median overall survival for patients who received chemotherapy was 51, almost 52 months versus 35.4 months. So those labeled low and CTC high, significant survival benefit with the use of chemotherapy, but for the others, it did not make much of a difference. The median survival with endocrine therapy with low was 5 years and high with chemotherapy was 3 years. So I think the authors felt that CTC count as a biomarker can help you in your clinic in deciding whether you should actually decide to go for chemotherapy or endocrine therapy. CTC count actually confirmed the allocated treatment in 60% and changed the plan in 40% of patients. So, and this is a long-term follow-up as well. And the and the future trials could actually look into this. So the downside of this study is this trial was designed before CDK4/6 inhibitors became standard of care. The dilemma still continues whether you would give endocrine therapy or chemotherapy to these patients, and also there are some issues related with the CTC methodology, which I'm not going to get into. The AMBER trial has put this in prospectively, and hopefully may change practice based on the results. The next paper is looking at real-world data to assess the utility of cell-free circulating tumor DNA in looking at resistance to early treatment in advanced breast cancer. So CDK4/6 inhibitors and PIK3CA inhibitor alpelisib are standard of care and are being used in the clinic, but the resistance mechanism to both of these is what this paper is trying to look at. Patients with advanced breast cancer were identified through a Guardant-informed database, and they were included if they had a liquid biopsy done within 90 days prior to treatment initiation and or 90 days after treatment discontinuation with either a CDK4/6 inhibitor or alpelisib. And also what they did was patients with RB1 loss of function alternates who got CDK4/6 inhibitor, and those with PTEN loss of function alternates who received PIK3C inhibitor were identified separately, and then a matched pair analysis was done 1:3, and they were matched with an RB1 PTEN negative population by age plus minus 5 years, sex, year of cfDNA test, and line of therapy. And they looked at time to treatment discontinuation and time to next treatment. And as you can see, if patients have been on PIK3CA inhibitor, the longer they were, they developed ESR1 mutation and RB1 loss of function. Being on PIK3CA inhibitor, the value of the PIK3CA alternates went down, which was expected. So patients with RB1 loss of function alternates prior to starting the CDK4/6 inhibitor had worse time to treatment discontinuation versus controls, but it did not make a difference to to alpelisib with the PTEN loss of function. So I think by looking at this, we are able to look at the clonal evolution and also able to characterize the resistance mechanism to both CDK4/6 inhibitor and PIK3C inhibitors by identifying specific ESR1, RB1, and PTEN alterations. So there is lack of standard operational procedure for cfDNA pre-analytical preparation, so I won't again get into this. And also the recent guidelines do not recommend liquid biopsy in routine clinical practice to detect molecular residual disease or molecular relapse. One must keep that in mind. Coming on to the early breast cancer studies, looking at circulating microRNAs for neoadjuvant chemotherapy in breast cancer. We know that response, we had a long discussion about this earlier, that response to neoadjuvant treatment is predictive and prognostic in HER2 positive and triple negative breast cancer. This was a study done in Ireland, prospective multi-center trial in 120 patients treated with neoadjuvant chemotherapy, and they looked at the baseline predetermined microRNA panel, and they tried to see whether circulating mRNA levels at diagnosis and done at a midpoint of neoadjuvant chemotherapy, whether they are able to predict the response to neoadjuvant chemotherapy, and these were the 5 target microRNA levels and 2 controls which were selected. In the overall cohort, none of the microRNAs correlated with response to neoadjuvant chemotherapy, but when a study is done, we have to find something significant. So there were 2 things which were significant. In L-HER2, increased LET7A expression, they were more likely to respond, and HER2 positive, this is luminal HER2, and then HER2 positive, decreased microRNA 145 expression, these guys were more likely to respond. So these biomarkers could allow individualization of treatment, yes, and responders could continue treatment as planned, and if you know that these are non-responders, these may proceed to surgery. But I think simple clinical examination will probably do the same thing as well. And the downsides of this study was single region, not extrapolable globally, small number of patients. The microRNA panel was chosen in 2008. Since then, newer microRNA targets have been identified, and we know about the TAILOR-X and the responder trials. They do tell us which patients, both in neoadjuvant and adjuvant setting, which patients can be spared chemotherapy. And also the Professor Mitch Dowsett's study, that Ki-67 done at 2 weeks, also may be able to predict the same, again, though there is no consensus on that either. The last paper looked at circulating tumor DNA and late recurrence in high-risk hormone receptor positive breast cancer. We know patients with hormone receptor positive breast cancer can recur up to 2 decades, 3 decades later as well. And nowadays, in high-risk patients, the duration of endocrine treatment is now increased to 7 years or 10 years based on what your endocrine treatment choice is. So I think it will be very nice to know which are the patients who are going to recur after 5 years, and which patients actually need prolonged adjuvant endocrine treatment, because we know that it does come with its own risk profile. So this study actually was very well designed, looked at minimal residual disease via plasma ctDNA. 83 patients identified from the NCCN Breast Cancer Outcomes Database, all patients treated at Dana-Farber. High risk was standard. They collected the archival tissue of the patient, then extracted the DNA, and from that DNA they actually they made a personalized radar assay, which was a patient-specific primer panel. So you can understand the costs that have gone into it in personalizing the assay for every single patient. And then the plasma was obtained every 6 to 12 months when the patients were coming for their follow-up. And so 8 patients out of 83 were MRD positive, 75 were MRD negative. So the overall sensitivity based on this small number for ctDNA detection, which identified a clinical response, clinical recurrence was almost 86%, and a negative predictive value of almost 99%, which actually looks great. Of the 8 patients who were MRD positive, 6 of them had a systemic recurrence. 1 patient had a locoregional recurrence, but the ctDNA in that patient was negative, which again is reflective of quite a few other studies that have been done. So as per the authors, the MRD was strongly associated with distant metastatic recurrences more than 5 years from breast cancer diagnosis, with a median lead time of approximately 1 year. So this was a very small cohort of patients, a very small number of events. The follow-up was only 2 years, and also these patients were followed up as per routine practice. So none of these patients, when they were MRD positive, actually underwent body imaging. So we talk a lot about anxiety when a patient comes to our clinic. And I think one of the oaths that we take is do no harm. By doing these blood tests, when we don't know what we are going to do with these blood tests is unintentional harm. We really need to look at clinical validity and utility in these patients. So to conclude, I think cost is prohibitive currently with these assays. Which technology is important? You must consider the strengths and shortcomings. I think liquid biopsy, where I see it, new space for drug development, yes. Treatment de-escalation or escalation, for me, treatment de-escalation in patients with advanced breast cancer is a strategy which is very attractive in advanced breast cancer. So yes, this is a maybe. Minimal residual disease and identifying super responders, I don't know where this will take us. Thank you.